Good afternoon, everyone. Welcome to this afternoon session to continue the excellent discussions on degenerative cervical myelopathy, or DCM. We're now going to have something of a debate. In a moment, I'll hand over to Mike Grevitt, who will set the scene with a case presentation, and then we'll move on to the arguments either for or against a surgical intervention in an asymptomatic patient with cervical cord compression. Over to you, Mike.
Thanks, John. Can you hear me now? Yeah, thanks, John, for that. I think these are my disclosures there, and the last one probably is important because a lot of what I have is necessarily conflated looking through the lens of someone with a busy medical legal practice. And this is a saying from William Blake there, and you can read it yourself, and they're all saying that hindsight is 20/20. But where the problem is for us looking forward and trying to anticipate future problems. And the title itself is a little bit of a misnomer because the truly asymptomatic patient is the one that doesn't even feature on our radar. They won't even get an MRI scan. So for many, beyond the patient who has frank myelopathic symptoms, is a gradation of gray and how those symptoms fit in to our paradigm and decision-making process. So let me offer you a 54-year-old right-hand dominant office worker who in 2013 presented to her GP with left shoulder pain. And her notes at the time just merely said that this was a musculoskeletal problem. She was given some simple analgesia and she went away. However, a year later, it transpired that she had increasing neck pain, numbness and paresthesia in her dominant hand. And it was accompanied by some occipital dysesthesia. She described it like a water sensation at the back of her head. On examination, she had reduced right biceps and supinated jerks, but otherwise no long track signs. The GP was concerned because of potential escalation of her symptoms. This is the report of the MRI scan. I'm sorry, I don't have the images from that time, but you can read it yourself there. So in association with the congenital block vertebra at C4-5, you can see there's some degenerative changes with some impingement on the cord, but no frank compression and no signal change. So given the information that you have here, and in order to perhaps give our debate principal antagonists or viewers to what they're up, can I have a show of hands as to who, given the information that you've been provided with at present, would either recommend or indeed would commission surgery on this patient? Can you show of hands? Okay, all right, so there we have it, very few takers. So she had a neurosurgical opinion the following year because of the waiting times, and at that stage she had constant right brachialgia, and although of fluctuating severity, it was nonetheless intrusive and been present for 2 years by that stage. She had tingling and numbness in the right thumb and index finger, and she had cough and sneeze impulse, which she described as pain in the back of the neck. Now, whether that qualifies as limits, I don't know. And the surgeon who saw her at that time wrote, "I suspect this lady will come to eventually require 2-level anterior cervical disc surgery, but as is the way often the shared decision-making is that they would not proceed with any action." Fast forward 5 years later, she was involved in a low-velocity rear shunt accident, so the relative collision speed was probably less than 30 miles per hour. And some 2 months later, as well as increasing neck pain, she developed bilateral upper limb paresthesia, what she described as novel heaviness in the left hand and some tightness whenever she tried some fine manipulation. And as the next 6 weeks elapsed, she developed progressive problems with balance. And on examination this time, she had very brisk reflexes. She had inverted supinator reflex. The Romberg's test was negative, and she had an otherwise normal tandem gait. The scan at that stage, you can see there, which you can appreciate even from the back, that beneath that block vertebra, there is some compression of the cord with some signal change. And those of you perhaps sitting at the front might appreciate that on the left, there is some intramedullary signal change on the cross-sectional area. And really, in terms of the medical legal side, one of the things that is involved in this case is, but for the motor vehicle collision, would she more likely than not have developed myelopathy? And if that is the case, when would she have developed DCM? And really, apropos this debate, and really going to heart to our protagonist to convince us otherwise, do we have enough data to support action to avoid future harm? Not necessarily in this case, but in general where some of those symptoms are very soft and very grey. So thank you very much, John.
Okay.
Thank you, Mike. Could I just ask one question? Is the inference that that scan had progressed from the earlier scan then?
Well, the answer, we don't know.
Okay. So I'll now hand over to Brian Kwan, who will start with the arguments for clinical observation without immediate surgery.
Okay, great. Right, well, thank you. It's a very provocative debate, and I think it's a great topic because it is something that I think we all struggle with to some extent. So I'm very pleased to be up here debating my good friend Mark Cotter about this issue. And we're really, I think we're going to have a friendly debate, but I think we're really going to just provide the arguments because I think we all have our biases and whatnot, and we're going to try to paint the picture from both sides of this this story. And I'm going to start. We actually switched the order, so I'd start with the argument for observation. Because we added, actually, it was originally listed in the program in the opposite, and I think it's probably good to start with the argument for observation. So this was the case that Mike sent me, and it describes this woman with this that I guess had the evaluation by the neurosurgeon in 2016, canal stenosis at C5-6 beneath a congenital block vertebrae, significant neck pain, right-sided radiculopathy, no upper motor neuron signs. So I think the most important thing to kind of point out, and Mike made this point, is that it's not actually a totally asymptomatic patient. So while this was an argument about, what should you do with the asymptomatic patient, this is actually a patient that has some symptoms, and I guess based on the story, actually has some cord dysfunction as well. So that does change things. But in the asymptomatic case, there is a term for this, and this is the non-myelopathic degenerative cervical cord compression patients. So subjects that have potentially plus or minus symptoms of radiculopathy and pain, but no myelopathy changes. So the challenge, of course, is that we don't have the crystal ball to be able to say what is going to happen to this individual in the future. And so this is all about risk and all about trying to measure that risk in individuals that present with these types of imaging findings. This is actually a patient that was in our institution. He was evaluated in January of 2022 with this MRI, presenting only with neck pain. He had no myelopathic symptoms at that time. And the decision was that he was going to be observed. And we had an icy period of time in February in Vancouver, which is very unusual for us. It snowed. And he slipped on the ice on March the 1st, and I happened to be on call. And he presented on March the 1st with a cervical spinal cord injury. And you can see the little bit of edema within his cord. And so he ended up I ended up taking him for this operation. So I think the hard truth is that we know that bad things can happen. But what do we know about the risk in patients who are asymptomatic, as this patient was? Surprisingly little. And I think that's one of the first things to maybe point out is that when you're looking for evidence about what exactly to do in this patient population, I think it's important to note that this is an area where there is a significant knowledge gap. I'm going to present to you some of the papers. There are 3 papers that kind of float through the literature that describe this potential issue. And the first is this paper by Bednarik and his colleagues, where he asked the question, are subjects with spondylotic cervical cord encroachment at increased risk of a cervical spinal cord injury after minor trauma, like that which Mike presented? This was a study of 199 patients. They had presented with symptoms of cervical radiculopathy and neck pain, and MRI findings of cord compression, but no myelopathy. So very similar to the case from 2016. So plus or minus radiculopathy, no signs of myelopathy, but MRI evidence of cord compression. And they asked the question, what happens to these patients if they're subjected to minor trauma? And they described trauma in the following manner. So this is trauma, the head, neck, spine, trunk, any falls, any high energy accidents, trauma that might render the patient unconscious, any fractures, anything that required surgical treatment, transient neurological deficits. These were all called trauma. So they looked to see what would happen in these patients and did they have any signs of trauma prospectively. So 200 patients, they found that over the follow-up period, 45 of them developed symptoms of myelopathy, whereas the 144 patients didn't. They identified in this cohort 14 traumas, three of which occurred in the patients that did develop myelopathy, and 11 that occurred in those that did not. And what they have essentially described is that in these three patients, in 2 cases of these traumas, the myelopathy became symptomatic 6 months before the trauma actually occurred. And in 1 case, the manifestation of myelopathy occurred 4 years after the trauma occurred. They concluded that there was no statistically significant association between traumatic events and the development of symptomatic myelopathy in these patients that were studied prospectively. So, to the question of whether or not they're at increased risk of cervical cord injury after minor trauma, the message from this paper was that no, they're not. And this was at least not in the 200 patients that they observed over the course of a minimum of 2 years follow-up. So that's very interesting, and that represents probably one of the only prospective studies that have kind of looked at this question. But this is just 200 patients. And what about if you were to examine this at a population level, where the denominator would be a bit different? Well, for that, we return to the Taiwanese National Health Insurance System. So they have a national health insurance system where they're able to collect health and at least administrative data from their entire patient population. And from this emerged 2 important papers in 2013 and 2012. And these have been widely cited as evidence that asymptomatic cervical spondylotic myelopathy in OPLL patients are at higher risk of suffering a spinal cord injury if left untreated. So let's look at these papers, starting with this first one, which was about cervical spondylotic myelopathy. If you read the abstract, and if you just read the abstract, you would say, oh, spinal cord injury was more likely to occur in the CSM patients who were treated conservatively with a hazard ratio of about 1.5 as compared to those that underwent surgery. So there was a statistically significant risk of experiencing a cervical spinal cord injury in those that were treated non-operatively. So the message that one might glean is that if you don't operate, these patients have a higher chance of suffering a cervical spinal cord injury. But if you look deeper into the paper and look at how they describe the patients that were included, all of the CSM patients identified were actually identified because they were hospitalized for cervical spondylotic myelopathy. So these were patients that they identified because their hospitalization included the diagnosis of cervical myelopathy. Some were treated surgically, some were treated non-surgically, and it was this patient cohort that was followed for a year. And in these non-surgically treated patients, the hazard ratio is 1.5. So these were not asymptomatic patients with cord compression. These were patients that were actually identified because they were hospitalized with a diagnosis of cervical myelopathy. The next paper is that in which they did a similar type of population-based analysis, but for patients with OPLL. They identified patients with OPLL that were hospitalized with the ICD-9 code for OPLL, and they followed 265 of these individuals and compared them to a comparison group that they matched statistically, which included almost 5,000 patients. And they found a hazard ratio of 30. So statistically, significantly higher risk of developing a cervical spinal cord injury after this in the ensuing time. But again, these were not asymptomatic patients. These were patients that were hospitalized with OPLL at one point in time. And so, in fact, the incidence of hospitalization, subsequent hospitalization for cervical spinal cord injury is far higher in the OPLL group. But again, these are not patients that were deemed to be asymptomatic from the outset. And they actually say this in their paper. So this is from the discussion of their paper. There may be patients with OPLL who have never been hospitalized and whose natural history may be different than patients enrolled in the study. And the present study is unable to ascertain how many patients who are never hospitalized with OPLL would later have a spinal cord injury. In essence, the question of what to do with the asymptomatic patient is not really informed by this particular study. And they even say so. Now, I would say that these are actually very important papers. They leveraged a national healthcare system to examine the question of spinal cord injury risk in patients with CSM and OPLL at a population level. And the risk of suffering a spinal cord injury is increased, particularly for the patients with OPLL. But at baseline, these are not asymptomatic patients. They were identified because they were hospitalized with the condition in the first place. And I think that's an important thing to consider. So there are interesting features to this case that Mike presented. And one of them being that this patient actually had right-sided radiculopathy. And if we look at patients that are particularly asymptomatic that have potentially these symptoms, it is known that the presence of radiculopathy is indeed a risk factor for the subsequent development of myelopathy. So this is also from the Bednar group, and they looked at patients that were indeed asymptomatic and what were the factors that predicted the development of subsequent myelopathy. And in this case, radiculopathy turned out to be an important factor, and significant cord compression. So I would say that definitely this type of individual is the kind of individual that one would want to follow because of the fact that they probably are at higher risk of developing myelopathy, which is a very different thing than actually developing or suffering a spinal cord injury. I think the block vertebrae also at C4-5 is of interest because it does potentially lead to some degree of instability at the adjacent segments, and I think that's also something important in this case. But I think when we talk about the argument for observation, I think one of the strongest arguments for observation actually comes from my colleague, Dr. Mark Cotter. Because Mark and his colleagues, in the wealth of information that they have and all the contributions that they've made to the myelopathy field, also wrote a paper about the prevalence of asymptomatic spinal cord compression on MRI. And what they found, and these were data that actually Mark presented yesterday in his terrific keynote address, is that the estimated prevalence of asymptomatic spinal cord compression in the healthy population is massive. It's massive. So a lot of people are walking around with spinal cord compression of an asymptomatic nature. And if you're healthy and walking around with spinal cord compression, then how could you make somebody in the healthy population unhealthy? Well, you could operate on them. And there is mounting evidence, and everybody knows this, about the potential risks associated with surgery. So surgery is not a totally benign thing. This is from our Canadian Spinal Outcomes Research Network. It's a very new paper. It's published in March of this year. And they actually looked across the board, across Canada, in our outcomes registry, that in fact, a number of patients will actually deteriorate their neurological function after surgery. In this case, the rate of deterioration was almost 1 in 10 patients. Sometimes that wasn't totally neurological, but on the MJOA score, they saw deterioration in not an insignificant number of patients. This is a study of over 40,000 patients in a US database that looked at predictors of complications, specifically with the interest of looking at frailty and how that potentially affected adverse events. And so they did this kind of analysis of which types, what frailty measures might better reflect the incidence of adverse events. And so we're not going to get into that. I just want you to look at the adverse events. So there are the adverse events: mortality, major complications such as pneumonia, DVT, MI, cardiac arrest, infection, sepsis, CVA, unplanned readmissions, reoperation, and discharge to non-home destination. So these are the kinds of adverse events that unfortunately can happen with individuals that undergo surgery. So how could you make somebody who's asymptomatic, residing in the healthy population with spinal cord compression, unhealthy? Well, you could potentially subject them to these complications. So we all have pride as surgeons. We all think that we're good surgeons and that this won't happen to us. But these two papers actually represent kind of what happens out there in the general population. And so I think we need to be mindful of that. So if you're going to be advocating doing surgery on non-myelopathic patients that otherwise are asymptomatic, then you have to be prepared to have some unhappy patients. So what do I actually do in my practice? And I think that, it's always good when you're part of a debate to say, well, what do you actually do? Well, I'll tell you, this is a case that, and this is probably one of my most dramatic cases, but this is a 44-year-old male, active runner, skier, cyclist. He's from Vancouver, but he was involved in a minor motor vehicle accident in the United States and presented back to my clinic for follow-up, totally neurologically normal and otherwise asymptomatic. And he had this in his spinal canal. So he's in a posterior enchondroma, and he had an MRI that looked like this. Totally asymptomatic. And this was in 2006, but it has been my practice, and I guess from my fellowship training, that you can't make somebody who's neurologically normal better than neurologically normal. And so we had a lengthy discussion, and we agreed to have sort of regular follow-up. This was him in 2006. So I follow him every 6 months, and he recently contacted me. In March of this year, we had another revisit. He's actually now starting to develop symptoms down his left arm, which are transient, that he gets with exercise, and he can kind of relieve them with certain movements of his neck. But for me, this has given me the excuse to actually operate on him, but he has previously, to this date, been asymptomatic. So I've been following him for 16 years. 16 years. So I'm not operating on this patient unless they actually want a radiculopathy operation, which I think the neurosurgeon that saw her actually kind of suggested. But like my patient that I showed you, I think that mandating routine follow-up and for these patients that are non-myelopathic but may or may not have radicular symptoms is really important. So I tell them, they're coming back to see me in 6 months, and if anything should change, then they should contact me, because I think that they definitely need to be reassessed if they start to develop some symptoms. But I'm not actually advocating for operating on them in the absence of myelopathic symptoms. This is also actually consistent with what our guidelines were in 2017, that in the absence of radiculopathy, we do not suggest offering prophylactic surgery, and in the presence of radiculopathy, that surgery be considered for these patients. But I think one thing is true is that certainly letting them go off into the wilderness and not following them is definitely a bad idea. So with that, that is the argument for observation, and I will leave it to my friend and colleague Mark to convince you that you should be operating on all of them. Thank you.
Yeah, of course, you're utterly wrong, Brian. Just as a disclaimer first, I don't operate on asymptomatic patients, but I'll take my best to make sure that you will operate on these going forward. This is the case. This is exactly the case that we should consider. Your case is fine. You see him a month later, he has this slip, and he's now, badly injured. So we can't take these risks for our patients. And this is good surgery and makes a difference. So we should really consider these surgeries early. Myelopathy, spinal cord injuries, tight rope, a small little flicker, and things change. So we have to be on top of this. And actually also just consider what I told you yesterday. It's a terrible condition. And maybe we should avoid it. Not sure at all costs, but here. So 95% of the patients that we operate have incomplete recovery for DCM. So they actually don't get back normal. So if they are normal, why don't we keep them normal? 40% unable to return to work, 50% reliant on others, poor quality of life measures. This is devastating. We should be careful, and we should make sure that we have that on top of our mind when we're seeing these patients. And of course, the pathology, it's devastating, it's awful. This compression isn't a subtle thing on an MRI scan. It basically causes loss of white matter and gray matter. It's something to take serious, even if they don't have any symptoms. And of course, coming back to this thing, it's not only the patient that suffers when they have DCM, it's the carer that suffers as well. So both patients, some of the lowest quality of life scores ever measured, carers, same thing. It must be terrible to live with someone with DCM. So you're not treating only one patient, you're treating a social construct, the family, the carers. We need to bear that in mind as well. And of course, the other data that's very strong is that the longer we wait, the worse it gets. We lose dependency, and the patients actually lose employment status. That's another reason why we should operate on these patients as soon as possible. DCM is not only bad in terms of the short run, in terms of symptoms, it actually also decreases your life expectancy. And if you operate, you get back to normal if you operate when it's still mild. So another argument for an operation. And this can all be summarized in one aspect, which is time is spine in this condition. So yes, you say, some patients with myelopathies stay stable over long periods of time. Have we observed them long enough? Maybe it takes 16 years until they become bad, and then now you've changed your mind, you see. The other ones that we see deteriorate, and of course, we can only give them a little bit of recovery. And because we don't know which one these go, we need to operate. This is a few patients that we followed up in our system, and we just looked at how they fared over time. And you can see these are sort of multiple, we color-coded this over time, and you can see many of them deteriorate. And actually, when we look at Cambridge, you can see people waiting for the surgery and actually deteriorating, dropping MJOR points. That's not acceptable. 5 points sometimes in this cohort is lost. We can't wait so far. And then the other big argument for this particular case, first, 23% in a median of 44 months follow-up deteriorate. And that's it, just project this into the future. If that rate continues, maybe our data is wrong. We just have to look at that paper. And then the other thing, you mentioned it, this patient has risk factors, which is, probably he hadn't had an electrophysiology assessment, but radiculopathy is a known risk factor. So I think surgery is safe, it's effective. I operate, I don't get the deterioration that you see in your Canadian cohort. And so I think there's a very strong case to make for the operation. Thank you.
Thank you for those excellent talks. Just as a follow-up to Mike's straw poll at the beginning, I'd like to ask a slightly different question. After hearing all of that evidence, could I just have a show of hands? Who would offer surgery to a patient who, A, has significant, in your view, spinal cord compression, but no myelopathic symptoms or signs, but also, B, has radiculopathy related to that level? How many would offer surgery? Significantly more. Do we have any questions for the panel or comments? I might start with one. I was interested, and I'm sure others were, to hear that you followed a patient up for 16 years. I'm afraid in the UK that would be impossible, both in the NHS, because we don't have capacity, and privately, the insurers don't cover chronic conditions. And I think the main question I have for these patients in my practice is, how often do you follow them up, and for how long?
Yeah, so I generally tell them that I want to see them back in 6 months. But he has my email address, so he emails me, because he's somebody who I'm quite concerned about. And so every year I get an email from him. How's it going? And I've had very lengthy discussions with him about his cervical spine and the risks associated with surgery. And he's a very knowledgeable, rational individual, and he kind of weighs he knows that there's potential complications of surgery, and in his mind, the calculus for that in the setting of having no symptoms, really, we've had a shared agreement that we would continue to follow him, but he emailed me actually in the fall to say, hey, I'm starting to get some arm symptoms, so
a particularly dramatic scan of his
It
as
is
well.
a particularly dramatic scan.
Mike.
Yeah.
On the dramatic scan front, did you let him ski?
I have actually told him that, and he's aware that he's at some risk associated with traumatic events. But to be honest, he continues to enjoy skiing and cycling, and he's an active guy. And I said that he has had that thing in his spine for 40 years probably, or 40, for 30 years, and along the way, and he would say himself, yeah, like I've had incidences where I've fallen and I've had without any symptoms. So he himself actually acknowledges that prior to his diagnosis, he knew that he had had many events and injuries and whatnot. So
this comes into another very important point, which I think you briefly mentioned then, which is the concept of shared decision making. Because frankly, if I had a spine like that, I would not want to be playing professional rugby. But that should be left to my decision to a degree, with us giving us the best advice we give them. And I think that's a really difficult concept, because what you want to do at 82 with cervical canal stenosis is very different if you're a 44-year-old skier. I would have given it up, but there you go. That's all I'm saying.
yeah.
Umar Gabar from University of Leicester. A follow-on question from that is then, what do you advise your patients? Because I get asked this question for the asymptomatic. What should I avoid, doctor?
Yeah.
What do you tell them?
So when I don't see asymptomatic patients, but we do see mild patients. And just like Brian said, we're going to follow up on those. And initially, I take it a bit more concerned with 2-3 months follow-up and tell them if anything changes, come to me. And then we space it out to maybe a 6 months follow-up period, and then maybe it's a 12-month until I then say, if anything has changed, and you had a few conversations with them, and so they know what they look out for, come back to me. So I keep it open, not discharge them, but it's patient-initiated follow-up. What do I tell them? So I think we just have to tell them, look, when you fall, it makes sense that your risk of an injury, a spinal cord injury, is higher. But, most of the falls, even severe falls, actually don't cause a spinal cord injury. So, there's we need to sort of mitigate, it's up to you, us together, to make that decision. And this is what happens when you have a surgery. These are the risks that you have when you have surgery. And in most cases, it's a dialogue that starts at this point in time. And you'll see that many patients take initiative and if you have enough time to discuss with them, or you have enough touch points, they come to something they can live with, which you then also can live with. Of course, there's no role now in that context to sort of take unilateral decisions. I mean, that just doesn't work.
I agree, it's usually a joint decision. I do point that to my patients, because I don't know what the answer, what should you avoid. You can't wrap yourself up with cotton wool and bubble wrap, because sometimes a simple fall can give you a central cord syndrome.
Yeah.
They're so tight, especially the example you put.
And I think patients are actually okay with us not knowing.
Yeah.
When I have that discussion, I think that, the patients actually, once you describe it to them, they're okay with the fact that we don't actually know, exactly what their risk is and I'll tell them that, yes, I do see patients that fall and suffer a hyperextension injury to their neck and have a significant spinal cord injury, I will tell them that we also don't know what the denominator is for all the people walking around with asymptomatic cord compression that are involved in motor vehicle accidents and fall on their foreheads and etc. So I think that it's okay to tell patients where our knowledge gaps are, and so they realize that this is a dialogue that doesn't have hard and fast science behind it, and we can only, as I say, try to measure and describe risk to them.
Yeah. I mean, you do say, hey, you're at higher risk, so, be mindful if you do certain things. Maybe you shouldn't. But ultimately, it's their decision. I mean, the flexibility that patients have in terms of or accepting lack of surgical evidence is much higher than I thought. As you know, we run this trial, which is a laminectomy versus laminectomy fusion trial. This is two invasive big operations, and our biggest fear was the patient didn't want to be randomized because they felt that their surgeon should know. And actually, they're happy. I mean, we've randomized, recruitment is going really well, not only in our center, but in other centers as well. So it's quite disarming if you just talk to the patients, we don't know, but this is the option. Let's get together to sort of make the best of what we know.
Mark and Brian, can I just interject there? Because we've been talking about risk, and I don't know if you were with our legal colleagues in an earlier session where we were talking about Montgomery and what we call the test of materiality in risk. And for those that are unaware, a material risk is those of a patient, a reasonable patient in a similar position to which he would attach particular significance. So in a situation like this where you have shared decision making, how can you document that shared risk assessment in the context of a consultation note? So people's perceptions of risk varies depending on whether they are inherent risk takers or they're basically very conservative, nervous individuals. Brian?
Well, I mean, I guess I will always document that I've had this conversation with patients. Usually the patient, like the more common one is the patients that are actually mildly myelopathic or are symptomatic. Although it's not unheard of course, to see, the patient that shows up because they read their MRI report and they have some cord compression. They totally are indeed asymptomatic. And I will tell them that, that there is probably some degree of risk associated with trauma, but that it's really hard to really put a number on that. And I will actually most people will actually acknowledge that, oh yeah, no, I have had a fall in the ski hill, or I have had a fall, and oh yeah, you're right, like I guess I've been okay. And so I think that it's important for people to get to that point where people can acknowledge that there is risk, but that no, they have been active for years leading up to their consultation, and they've been fine. And so I generally will just document that we've had that conversation and that they understand, but that that I haven't advised them necessarily to stop skiing or stop cycling or whatnot.
I think this is really where the guidelines hopefully create some support, where essentially, if you look at the guidelines for mild myelopathy, they say surgery is an option, but also, a structured course of of rehabilitation is an option, and I think those guidelines already tell, hopefully, the legal system that there's no clear path, and as long as you lay those options in front of the patient and have this discussion, I would be hoping that the legal system accepts that.
We've probably got time for two more questions, I think. I can see Mr. Golash there and then Mr. Gibson, but I think we're probably going to run out of time. Sorry about that. Mr. Golash.
Thanks. I think Mike read my mind and asked the same question, especially if our consultation is being recorded. It will be even more worrying. But let me ask something different. Is there any evidence of neurophysiological monitoring, like a magnetic transcortical stimulation, to follow them to develop any preclinical problems so that we can act early?
I think that's a very interesting question, and there's been some very interesting research conducted at the moment in Berlin, at the Charité, that sort of looks at, again, risk factors for deterioration. And this is, I think that's the key. We need to better make sure we can differentiate those patients or stratify those patients that are going to be safe in terms of deterioration and those that are at risk of deterioration, because then it would be much easier to make those decisions. So absolutely, I think that's the big thing that we need to tackle.
Alex Gibson Stanmore. So thank you for two great talks. Brian, your case that you showed with the dramatic-looking scan also had what appeared to be an obvious myelomalacia in the cord. So obvious that even an orthopedic surgeon could identify it from the back of the room. So does that influence your decision and advice to patients at all? We heard about the radiculopathy, but to my mind, if you've got myelomalacia, you've got established neurological damage in the cord at that point, even if it was asymptomatic according to your patient.
Yeah. Yeah, I guess in looking at that, I guess specifically for him, that's myelomalacia that probably was there 15 years before he even came to my office. And that's, that's an established, he himself is functioning normally with that cord. So, our agreement was that we would follow we would follow up regularly because of the fact that, what I don't know is kind of what reserve he has left in his very significantly compressed spinal cord, but I do know that, and he knows that he's functioning normally without any, and had he not had that accident, that was actually an accident, he would not actually know that that was what was happening inside his spinal cord. So, I think that in situations where that there's, and we counsel patients that have myelopathy symptoms with myelomalacia, that some of that may be permanent. But again, it's hard to make somebody more normal than normal when they're functioning that way.
Yeah, I mean, this is an extreme case, but one does see spinal cord compression, mild myelopathy with T2 signal changes and also myelomalacia. Now, in terms of the T2 signal changes, there is some little evidence that potentially the risk of deterioration is increased, but also there's other evidence that it might respond better to treatment. Nevertheless, when we considered this also as part of the guidelines, we felt that the evidence is insufficient to make any recommendations around this. And
surprisingly.
And the myelomalacia, exactly, it's surprising. Yeah. And the myelomalacia, as you said, this could have been a trauma that happened in the past. So I don't think myelomalacia as such it should be any. I think that is even less of an issue than T2 diffuse signal.
So you think it could be old established myelomalacia change that's not progressive and not current?
If there's no sort of diffuse, let's say, evidence of edema, it's a static process. So if you've got this sort of clear white bubble in the spinal cord, then I think there's even less reason to operate on them.
Thank you.
Fantastic. It just falls to me to close the session. I think it's coffee time. Please join me in thanking the speakers for an excellent debate.